If your NT is more than 3 mm or your fetus doesn't have visible nasal bone, or it is low, hypoplastic or small, or there is presence of cystic hygroma, that means extensive fluid collection behind the nape of the neck extending to the lower back also, there are high chances of chromosomal abnormality and or structural abnormality. Therefore, you will be offered a definitive diagnostic invasive test, which is chorion villus sampling before 14 weeks of pregnancy or amniocentesis after 16 weeks of pregnancy. If your fetus has NT less than 3 mm, we advise an add double marker test, so it becomes a combined test. So the software gives again the result of combined test in the statistical manner. If it shows low risk, that is 1 in 1000, the aneuploid is highly unlikely. Therefore, we reassure the patient that things are all fine. If the result is high risk, that is 1 in 250, that is the indication for you to undergo specific diagnostic invasive test to rule out chromosomal abnormality. Therefore, we recommend CVS or amniocentesis. If the risk is an intermediate group, that is 1 in 251 to 1 in 1000, here is the consideration of NIPS comes in picture, that is non-invasive prenatal screening or testing. Friends, remember, NIPS also is a screening test. It is much costlier, but it avoids unnecessary invasive tests in quite a few number of cases. What is the result? The result may be low risk, which is reassuring. You may not go for any further testing. If the result is high risk, then again one has to undergo diagnostic invasive test in the form of CVS or amniocentesis, because there is a very low but definite possibility of a false positive test. After invasive test, the patient may have spotting or bleeding PV for short duration, and the procedure specific risk of miscarriage is 1 in 300. What is the detection rate of NIPS? For trisomy 21, it is as high as 99%. For trisomy 18, it is 93 to 98%. And for trisomy 13, it is 99%. All these has a false positive rate of 0.04%. What about the post-test counseling for pre-eclampsia? If the results are low risk, we reassure the patient and just offer them routine prenatal care. If the result shows high risk, then I offer my patient tablet aspirin 150 mg per day from the day of the screening test availability till 36 weeks of pregnancy. The same applies for fetal growth restriction. Now, if there is high risk of preterm birth, if there is previous history of preterm birth or history suggestive of incompetent cervix in the past pregnancy, or if the cervical length is less than 25 mm or the subsequent scan shows shortening of the cervix, then what are the options we have? There are two options. One is cervical cerclage, that is tightening of os operation, and the second is vaginal administration of 400 mg progesterone daily till the patient completes 36 weeks of pregnancy. One can consider either of these two options. Friends, as far as structural anomalies are concerned, 10 out of 100 anomalies are detectable at 11 to 14 weeks of pregnancy. I will give you two examples. One is anencephaly, where the forebrain is absent, and second is acrania, where the fetal skull is absent. So, the counseling becomes easier because these two are uniformly lethal. The fetus cannot survive after birth, and therefore the decision making may be easier for the couple. But for other anomalies, we have to counsel the patient that these may be associated with chromosomal abnormalities in the fetus, and therefore we have to offer them an invasive test. We discuss about the prognosis of this condition, quality of life, level of disability, need for surgery, and the possible outcome. and we help the patient in a non-directive manner and help them in the decision-making process.